Good afternoon, everyone. On the behalf of Team Dentistchannel Online, I would like to extend a very warm welcome to all of you on the last day of second virtual World Implant Expo 2021. I'm Dr. Aditi Mishra, and I'll be the host for today's session on the topic Periodontal Surgical Considerations in Implantology by none other than Dr. Mayur Kaushik. So before starting with the session, I have few housekeeping notes to make. If you have any doubts during the session, I request you to drop your questions in the question and answer box, which you'll find in the control panel, and we'll be taking up the questions at the end of the session. If you have joined us from Facebook Live and YouTube Live, you can ask us questions by commenting, and we'll be answering at the end of the session. So without further ado, I would like to introduce our today's speaker to everyone. Dr. Kaushik has begun his career at Manipal College of Dental Sciences, Mangalore in 1996 and completed his MDS in Periodontology from GDC Nagpur 2005. He is currently working as the professor and head in the Department of Periodontology and Implantology in Subharti Dental College and Hospital, Meerut, where he has been working as faculty since last 16 years. He is the recipient of Dr. D.N. Kapoor Award, International College of Dentists. He has around 51 national and international publications and co-authored 14 books of this specialty. He has been actively involved in under and postgraduate training courses of implantology for the last 16 years and supervised 61 research projects till date. He is a well-known keynote speaker and has delivered lectures in many national and international conferences. He has been running his implant-based practice for last 1.5 decades now at Kaushik Dental Care, Meerut. He is also working as course coordinator and mentor at Rochelle Implant Training Center at Lokpriya Super Speciality Hospital, Meerut. Welcome, sir.
Thanks a lot, Dr. Aditi. I'm sorry for the delay. I'll just start with my screen sharing now. So, thanks a lot, all of you. Just 1 second. I think now it is visible, Dr. Aditi?
Yes, sir.
It is, yeah. So, Jai Hind and a very good afternoon to all of you. Thanks a lot for joining this session. I'm Dr. Mayur Kaushik. I bring to you greetings from Swami Vivekanand Subharti University, Meerut. Now, our university is a big university, one of the biggest universities in India. It has as many as 20 different colleges under its wing. I've been working in this college, as Dr. Aditi said. I'm about to complete 17 years now as an MDS faculty. And I've been working here ever since I did my post-graduation from Government Dental College in Hospital, Nagpur. And whatever I am today, it is because I had a godly figure as guide during my post-graduation, Dr. R.K. Altivar, sir. And these are few glimpses of our department. We are Team Perio Subharti. I'm the head of the department right now. I'm also the chief mentor in Rochelle Implant Training Center at Lokpriya Super Speciality Hospital. We are a team of 4 basically. So Dr. Rohit is the course director, and along with me, there is Dr. Sumit Makkad, who is a professor in Prostho, Dr. Prajesh Dubey, who is a professor in oral surgery. So we believe in a coordinated approach with regard to implantology. Rochelle actually is short for Dr. Rohit, and Dr. Shalya, the CEO of Swami Vivekanand Subharti University, his wife. I have a small dental clinic at my residence by the name of Kaushik's Dental Care, where I practice with my father, who is also a dental surgeon. And this is my small world. She's my wife, Nupur. And Dr. Nupur is a professor in Pedo in the department of Subharti, Pedodontics in Subharti, working for the last 12 years now. And she is our 10-year-old daughter, Adya. So I'm really thankful for this consideration of keeping me as a guest speaker. I had told sir about the busy schedule because today we have our Implant Academy also. So in another 1 hour, that is at 2 o'clock, after this lecture, I'm supposed to deliver a 2-hour lecture at that Implant Academy. That is an offline lecture basically. But somehow sir was able to, I couldn't say no to Bennett sir. So here I am. And this is what we'll be discussing today. As a dental surgeon, I'm not calling as an implantologist, as a specialist as such. Our main purpose is to ensure the smile of a dentist, to enhance the smile of a dentist. And one of the big reasons which completely destroys the smile of any dentist is a missing tooth. So there was an era of RPDs, removable partial denture, but that era is gone now. All of us know that RPD is a poor man's modality. So basically, what happens is they are one of the weakest modalities. The masticatory forces are not there. The psychological disadvantage is there. The patient feels that this might come out at any point of time. So RPDs are out. And then there was an era of FPDs. So everybody, the success of a dental practice used to be measured by the number of bridges a dentist was delivering in 1 month. But the main problem with the FPD was, of course, adjacent teeth had to be grinded quite a bit. So we were causing loss of vital tooth structure on the adjacent teeth. And now we are in an era of implants. So implants are the ones which actually determine our success as a dental surgeon, whether it is status, that is fame, or whether it is money. So without implants in our practice, I don't think so successful term we can use. That is my opinion as such. But with regard to implantology also, please understand this thing. The prosthetic component, the tooth structure, comes much later. It is the surgical component, the osteotomy process of drilling a hole inside bone, reflecting the soft tissues, placing a metal device known as the implant inside living hard and soft tissues, and making sure it survives, which actually determines the success of your implant practice. So basically, if the base is weak, the superstructure is bound to fail. So majority of the time, this is the blunder which I see many budding implantologists to be making. They try to concentrate more on this aspect. Some fancy material might be there. They'll are trying to find as many shortcuts as possible with regard to this surgical part. No, the worldwide accepted definition of implantology is it is prosthetic driven surgical treatment modality. So please understand this thing. If your surgery is weak, and I'm not talking about as a periodontal surgeon, as an oral surgeon or somebody, I'm talking about as a dental surgeon. If your dental surgery is weak, you can never be a good implantologist. And when I talk about dental surgery, I'm basically talking about I, R, and S. I stands for incision, R for reflection, and S for suturing. So please understand, there are no shortcuts to IRNS. If you want to be a good implantologist, I'll be giving just few tips from a perio point of view today, but this is the biggest tip you should take home. Do not try shortcuts in implantology. There are absolutely no shortcuts. Anybody who is advising, I'm doing flapless implants, I'm doing this implants, that implants, you can be very sure that that person is struggling with regard to incision, reflection, and suturing. Okay, no matter how good the CBCT report is, it is always the man or the woman behind the machine. So ultimately, unless and until you are visualizing the bone yourself, please do not go in for blind implantology. So with regard to this thing, if you go in for blind implantology, this is what you'll end up with. Okay? Your implant might survive, but soft tissue would be a disaster as such. So this is what I'll be covering. Periodontal consideration, periodontal surgical considerations in implant therapy. I'll try to keep it as short as possible because I also have to rush. I'm sorry for that. So the point remains the same whenever I talk about this thing here. Periodontist placing an implant. So wasn't a periodontist supposed to save a tooth at all costs? So any such person who issues such stupid statement, I refer them to this particular article of Cloakweld and Newman, the current authors of our Bible textbook, Carenza. So Cloakweld and Newman have clearly said that the current success of dental implantology has dramatically changed the philosophy and practice of periodontics more than any other specialty. There has been a solid paradigm shift in this case. The rules have changed drastically from the emphasis to save a tooth at all possible costs to a paradigm shift where we need to extract few of the teeth for the success, long-term success of implants. So ultimately, it is not like as a periodontal surgeon, anybody is supposed to save a tooth at all costs. No, we have to look at the long-term benefit of the patient as such. So these are the 5 contents which in short I'll be covering in the next 20-25 minutes as such. Okay? So we'll be starting with the first content, guided bone regeneration. So without guided bone regeneration, there is no implantology. I have to state this thing. Anybody who is thinking that without a knowledge of particulate bone grafting, without a basic knowledge of membranes, that person can perform implantology in his clinic, that person is in an eternal bliss. That person is in a bliss, but that bliss is not practical. So please understand, this is the basic scenario that we have in our practice. The patient who has ample bone doesn't have money for an implant. And the patient who doesn't have bone is telling doc, place an implant no matter how much you can charge. So ultimately, regeneration, we need to try to regenerate bone, and regeneration is part and parcel of majority of the cases that we end up doing. So I've just included one case here. This patient came to my clinic. She was an 82-year-old female, and at the time when she had come, her bridge was broken. These two teeth were broken, only root stumps were remaining. So this was fractured basically. In the radiograph, I got a CBCT done. The fracture was obvious. I had a huge periapical radiolucency was evident. So a lot of bone loss was there. So I decided, I just evaluated the amount of bone which we had apical to the roots of the teeth, and I decided to go in for immediate implantation. So these two teeth were already hanging. I removed them and I placed two implants. Now, would my implants have survived had I left them like this? My implant is like this, the tooth socket is like this. So, unless and until I am able to put some good particulate bone graft around this thing, will my implant survive? Definitely not. This is not a miracle which will happen. This is not some Feviquick or something which will be there. Won't my bone graft, even after proper condensation, be flowing out of this window at the apex? It will definitely be flowing out. So, unless and until I have a basic knowledge of membrane placement, I won't be able to do successful implantology in this case. So, what I did was I packed it up with a good bone graft. I'll be covering up what is good bone graft. It was FDBA from Tata Memorial in this case. And this bone graft was still flowing out. So the socket was self-retentive for the particulate bone graft, but in the apical area, the graft was flowing out. So that is where I put a periocol collagen membrane. This is basically a GTR membrane. Here I'm using it from a GBR point of view. But all these things are a waste if you are trying to search for shortcuts in dental surgery. So now you have put three foreign bodies: implant, bone, membrane. The most important thing here is primary closure. You should be able to give vertical incisions properly. Passively, you should be able to close the flap. That is the key. Implant is surgery first, restoration later. Please, we have to get this thing clear in our mind. Any person who is trying to guide us otherwise is not an implantologist. Anything which is invading the soft and hard tissue is surgery. So I had given this thing, but I cannot leave it like this. So you must be hearing a lot of things about immediate loading and also. Can we go in for immediate loading in this thing? Not at all. The bone graft won't be surviving only if undisturbed healing is not there. So straight away I delivered a Maryland prosthesis. Maryland prosthesis basically takes support from the adjacent teeth, and ultimately the patient was happy. This was the radiograph at the time of implant placement, and this was after 4.5 months. So just in 4.5 months, if your surgery is good, ample bone formation would be there. What do I mean by good surgery? Good surgery begins with proper sterilization. After sterilization, it is your hands. How good your surgical expertise is. That is what will determine how much you lab technician can play later on in the lab with the prosthesis. But unless and until your implants are surviving, you are not even giving your lab technician a chance to showcase his or her skills as such. So basically, at the time of second stage surgery, once I gave the incision, this is one of the side which um, gives greatest pleasure to any implantologist. That one implant is partially visible, the other implant was totally invisible. I had to pick up an aerotor and ultimately expose the implants. So please remember one thing: there is no implantology without particulate bone grafting. This is one thing which you have to understand. So just 2 or 3 tips I'll be giving, that which bone graft we should be preferring. So first and foremost, with regard to the type, comes the form. So it is particulate, fine. You have to use particulate because you have to condense it around the implant as such. But what should be the particle size? Should it be quite broad or should it be thin? The particle size is basically mentioned on the packet itself. It can be less than 500 microns or it can be 500 to 1040 microns. It can be even bigger. That's not preferred. This is the particle size you should be preferring. But why? The reason for that is that histological studies have already shown that the ideal particle size is the one which should promote bone growth, meaning it should not be serving as a permanent filler, another implant around the implant. No, ultimately it has to be replaced by natural bone formation. How will it be replaced by natural bone formation? Only if over a period of time it resorbs and natural bone forms. So what you have to understand is that ultimately histological studies have shown that the ideal particulate size is for such that once you condense that bone graft together, the interparticulate distance should be 100 microns. That is the key element of bone regeneration with particulate bone graft. This 100 microns distance should be there. If it is too much, that is detrimental. If it is less, that is detrimental. So for this, the particle size of your bone graft should be within 250 to 750 microns. So on an average, 500 to 1000 is acceptable. Now, what will happen? Why is this 100 micron important? This 100 micron is important because 100 micron is the diameter of an osteon. We are a doctor. We are doctors, not technicians. Unless and until we are able to apply the knowledge which we had gained in histology, physiology, anatomy, etc., to our clinical practice, that just wasn't for the namesake, those MBBS subjects. Those are because we are doctors. We are dental doctors. We are supposed to appreciate this thing. The interparticular distance has to be 100 microns because 100 microns is the diameter of an osteon. If it is too much, what will happen is osteonal bone growth won't be supported. A big particle size, if it is there, it will be remaining there only. It won't be getting resorbed ever. And if it is too thin, too small, it will be getting resorbed at a very fast rate. No bone formation would be there. So resorption should take a couple of months, and then that particle size, particle bone graft should be replaced by natural bone around your implant. So this is the thing which you are supposed to keep in mind. So which bone graft to use? We have four types. All of us have studied during our BDS time. Autografts, which site to prefer? My favorite site is mandibular symphysis area. So in another case from one of our dissertations, I have given an incision. We have reflected the flap, and the area preferred is the incisors. So central and lateral incisors, mandibular anterior. We can get a CBCT to find out the root length also. Why is this area preferred? Because canine would be having a longer root. Also, this is the area in which no vital structure is there. So you can go as deep as possible. Posterior, you will be getting mandibular canal, here maxillae, sinus, etc. So the instrument that you are supposed to use is bone trephine. This is just a 5,500 rupees instrument. This is the one which I'm using from Amron, but any company we can use. This has to be rotated at a very slow speed. So speed of 80 to 100 RPM is preferred. Now 80 to 100 RPM won't be there in a erotor. So what do you have to use? You have to use a physio dispenser only. Micromotor, if you use, it will get stuck. So in a physio dispenser, 80 to 100, now I've created my window here. So the moment you cross through cortical bone, it tends to dip a little. That is basically an indication you are in medullary bone. So once you are inside this thing, now you are supposed to, I'm using a Lucas bone scoop for this. I don't have time to cover the surgical armamentarium, but this is a Lucas bone scoop, superb surgical instrument in implantology for removing this bone. And then we have the exposed medullary bone. So we have to suture it properly. These are PTFE sutures which have been given. And finally, you require a second instrument for bone grafting around implants. This is basically a bone mill. So bone mill or bone crusher is again 4 to 5,000, 4,500 actually this one. And with this, we are supposed to crush it. So once we have crushed it, now we have our particulate bone graft mixed with blood to be used around implant. Advantage of autografts is they are osteogenic. They have the actual potential of forming bone around an implant because they contain bone forming cells known as osteoblasts. Problem is you need to induce a second surgical site to get that autograft. And then again, what happens is ultimately the quantity many times is not very great. So that is why my favorite category is allografts. as far as possible, you can use allograft. These are the FDB and Tata DFDBA bone grafts, which I've been using now since the last 19 years at least, from my first year of PG. And super bone grafts you can use, and you can be sure that all your immediate implant cases, all your cases in which no bone is there and you need to put bone graft around, particulate bone graft around, won't be failing as such. So these are the bone grafts which are preferable. But then again, Tata Memorial doesn't make it commercial. So in case you don't get a choice, you can go in for xenograft also. That is from animals. BioOS is good. BioCoral is fine. Not so easily available. BioOS, the problem is that normally that we face is that ox bone is supposed to be more stronger than human bone. So human bone is forming at one pace, but this is not resorbing at the same pace. So this is one problem which we get with BioOS. It doesn't resorb as easily as an allograft. That is a bone graft taken from another human being. This is ox bone. It resorbs at a slow rate, but still it resorbs. The worst bone grafts or other bone fillers that you can use around an implant are alloplasts. Please understand that had it been an apicectomy case, had it been a periodontal defect around a tooth, you could have used a bone filler. The same result would have been there. Pocket reduction would have been there. The stabilization from the surrounding bone would have been there, and no problem would have been there. But the problem is with regard to implants, you require osseointegration. You want bone to grow into the implant threads. You cannot satisfy yourself with just using a filler material. So as far as possible, I'm a sitting example. I have had lot of cases, lot of failures while using alloplasts. So please do not use bone fillers. One of the most dangerous, what do you say, categories to use among alloplasts bone fillers is bioceramics. Hydroxyapatite and beta tricalcium phosphate are two examples. The problem is the resorption time is not, what do you say, monitored. So many a times these companies, it is very easy to mix calcium and phosphate in the lab and you have a bioceramic. But the problem is resorption has not been taken care of. So you put it there, it will be there like a permanent filler. So your implant is not joined with bone, it is just stuck inside. Whenever some dislodgement is there, it will come out. And repeatedly, the patient will tell that pain is there in that area. So do not use bioceramics. Okay. And of course, membranes. Membranes, basically, the requirement of membranes in implantology is simple. They just serve as a bone graft retentive device. So always and always, you can go in for collagen membranes. Go in for resorbable membranes rather than non-resorbable ones. In resorbable ones, go in for collagen. Easily adaptability is better as compared to PGA PLA membranes. And then again, if anybody is telling you putting a membrane is a must, 100% that person doesn't know much about particulate bone grafting. Okay? If the site is self-retentive, meaning you have extracted a tooth and you feel the socket is huge, your implant is like this. You can just condense bone graft around the implant, but the socket is self-retentive. No need to use a membrane. Many people have this opinion that the particulate bone graft should not come in contact with the inside of the flap. That is absolute bullshit. Are you getting a point? Because each and every periodontal defect in which we are doing bone grafting, we are not doing membrane placement as such. So as long as the defect is self-retentive, it is not a necessity to use a membrane in each and every case of implantology or advanced implant regenerative therapy. Okay, by using a membrane, you are putting a third foreign body. So the overall size of the surgical wound would be more. Post-operative edema would be more. Chances of your sutures opening up would be more. So always and always, whenever using a membrane, the passiveness of the closure has to be even better. But it is not a must. It is not a must. Okay. With these few points, I move on to the second type: gingival biotype and soft tissue augmentation. So many a times in implants, we are obsessed. We are basically obsessed with only the bone part, and we literally insult the soft tissues. No, soft tissues are supposed to be the shield of bone. Please understand this thing. You insult the soft tissues will insult your implant properly. Okay. So you need to be careful to identify which type of soft tissue are you dealing with. So periodontal biotype, basically, the definition was given by Siebert and Linde in 1989, basically refers to the buccolingual thickness of the gingival soft tissue. So this can be of two types, basically. as described by Ocean Bean and Rose, thin scalloped or thick flat. So in case it is thick flat, nothing to worry. Even if your dental surgery, IRS is not up to the mark, even if we are not that meticulous or that gentle in dealing with the tissues, it will tolerate a certain amount of insert. But God forbid, if it is thin scallop type means scalloping means this curvature is more, it is thin. The instrument is literally showing itself on the outer side. You have to be very, very careful. Okay, current dissertation is going on in our department of Dr. Salil Joshi. So he is evaluating basically the soft tissue thickness around the bed where implant has to be placed, and then he is placing the implant, and then subsequently Dr. Salil will be finding out after 1 year whether bone loss is lesser in the thicker type as compared to the thinner type. And few of the studies have already shown this thing, that recession post implant placement is always more in the case of thin biotype, almost 1.8 times. So more recession means what? You have given a crown over your implant. Basically, lot of food lodgement will be there underneath that crown which you have given. In case you are gentle, that food lodgement would be lesser and your patient would be more satisfied. So please understand this thing. Thick scallop type is more resistant, and two changes you have to do whenever you are placing an implant with in a patient with thin biotype in the anterior region, anterior aesthetic zone, maxillary region. First and foremost, you have to shift it more palatally. If you don't shift it palatally, what will happen is, since the buccal tissue is thin, your implant's black shadow might be visible through the soft tissues. The no matter which zirconia crowns, etc., which we have given, patient will be telling you this crown is looking white, doc. But what about this black shadow coming up? So please place it slightly more palatally and plus place it more apically, deeper, so that the emergence profile is how the processes appears when it is coming out of the soft tissue. So the emergence profile actually is better. So please understand this thing, that ultimately um, soft tissue biotype dictates two things: how you handle the tissues more gently, more carefully, not just at the time of implant placement, second stage surgery also, impression taking also, and crown delivery also. And second thing, especially in the anterior zone, it will be dictating that you have to change the position of your implant. Otherwise, we end up cases like this. So again and again, openly, I say that whenever non-surgical specialties place implants, these things, these sort of accidents normally happen. So again, referred from another department to our department at the time of second stage surgery, lot of necrosis was there. So that necrosis was basically because soft tissue biotype was there. So ultimately, once we removed the gingival former, hardly any tissue was present. So the implant would have failed, even if it wouldn't have become mobile. What would have happened would have been, it would have been an aesthetic failure. So in this case, a surgery which we as periodontal surgeons do very, very routinely, connective tissue graft surgery, that is supposed to be done. So what I'm doing here is simple sub-epithelial pouch I'm creating. I put my 15 number blade. The 15 number blade is completely inside, and I'm creating a sub-epithelial pouch around the implant. After that, this is the site from where we are supposed to procure a connective tissue. Periodontal surgeons do it routinely, but this is one thing which every implantologist should be mastering. Every general dentist should be mastering, because without this, ultimately, these are cases which we won't be able to deal in the aesthetic zone. So in the area of premolar, we have to procure, keeping in mind the greater palatine artery. The I generally prefer the trapdoor. Few periodontal surgeons, they prefer the single incision technique or the parallel incision technique also. So two incisions we have given. These two horizontal incisions are only till the thickness of the epithelium. The vertical incision is actually bone deep, and this after this we tend to reflect a flap. So are you able to see the epithelium has been reflected, and we have connective tissue here. So this connective tissue now I'm procuring. Have we deepened the cuts? You remove it, and once this thing has been removed, this is how the thing looks like. But you cannot leave it like this. The main advantage of connective tissue graft surgery is healing by primary intention. You have to suture it back. This takes time to master. It is not that easy. Palatal suturing, and the patient is gagging majority of the time. So over a period of time, it becomes a piece, not a piece of cake, but still you have become proficient in it. But the point remains the same. Ultimately, what you have to remember is that implant is surgery. Anybody can place an implant where ample bone is there or soft tissue thickness is good. Your quality as an implantologist, as a successful implantologist, is how much of advanced implantology you can practice. And advanced implantology is nothing but particulate bone grafting and soft tissue surgery around an implant. So now I place that connective tissue. So this connective tissue basically was a little bigger. I had to trim it as such. Then with one suture, it has been inserted in this side, and with the other suture, has stabilized the other end. But this part is still exposed. So what we have to do is just like we do it around the tooth, the gingival former has been attached, and with cross sling suture. Sling is something which goes around. With a cross sling suture, corner displacement of the epithelium has been done to cover up the CT entirely. That is why CT connective tissue is the gold standard. Dual blood supply is there. Blood supply is there from the sides also underneath and from the top epithelium also. So this was the result hardly at 21 days ultimately, like just a month over, an awesome result was there. Result was maintained over a period of time, but after the process, the patient didn't come back ever. Not a localite as such, but we generally say in practice, no news is always good news. So we are expecting the best, but the results were very promising. So this is about soft tissue. The next thing is implant placement guidelines based on biologic width. This is another thing which you have to remember. Okay, biologic width by consideration while placing an implant. So please understand what is biologic width. Nature normally said that between the ending of the crown, the CEJ, where the crown ends and the bone begins, roughly 2 millimeter of gap should be there. This 2 millimeter gap should be occupied roughly by 1 millimeter of epithelium, that is junctional epithelium, and 1 millimeter of connective tissue. So this is known as biologic width. This is the width which actually preserves this bone. The importance of biologic width is this covering of soft tissue, this minimal covering of soft tissue is essential for preservation of the bone which is holding our teeth in place. So what did I say in the beginning? Soft tissue is supposed to be the shield of bone. So this is one thing which you have to remember. Suppose a patient comes to you, broken tooth, etc., and straight away blindly we cut the tissue. Now I expose the crown. Now I'll be delivering a crown as such. No, you cannot place your crown 2 millimeter within 2 millimeter of the alveolar crest. You'll be violating the biologic width, and ultimately the patient will be telling you, doc, constant pain is there. You had done the root canal treatment, everything was fine. The moment you placed a crown, doc, all my life became miserable. Why has the life become miserable? Your crown is too close to the alveolar crest. You need to reduce this alveolar crest by 2 millimeter using your burr, then only your crown will be successful. If this is so important in the case of a natural tooth, biologic width, where even PDL is present, this is even more important in the case of implant. So please understand the requirement of biologic width is actually much more in an implant as compared to a natural tooth. Here it is 3 millimeter average figures I'm saying as compared to just 2 millimeter. So please understand, and of course, connective tissue fibers cannot embed the way they embed perpendicularly in the cementum. Here they are parallelly placed. Okay, but PDL is missing, so ultimately blood supply is restricted. You need to ensure ample soft tissue is there. So please understand, it is this 3 millimeter guideline which dictates that 3 millimeter gap should be there between two implants which we are placing. Okay, 2 millimeter from the adjacent tooth, and 3 millimeter means 1.5 of this side, 1.5 of this side. This biologic width is subcrestal around an implant. So around an implant, how much is the requirement? 3 millimeter, 1.5 millimeter this side, 1.5 millimeter this side. So 1.5 millimeter is difficult to measure. Hence we say from the adjacent tooth, it should be 2 millimeter. But between two implants, how much it should be? 1.5 plus 1.5, that is 3 millimeter. So please remember the 1, 2, 3 rule of implantology. Whenever you are placing an implant in bone, once you have placed an implant, minimum 1 millimeter of buccal and lingual bone thickness should be present. Otherwise, chances of failure increase. This is 1. 2 millimeter, which we are placing an implant, minimum 2 millimeter should be there from the adjacent teeth. That is 2. And 3 millimeter. 3 millimeter means once you have placed an implant, please see before placing the implant that 3 millimeter space is present above the implant where you can place a crown or not. So 1, 2, 3 rule of implantology, where this 3 millimeter gap and this 2 millimeter gap is because of the periodontal surgical consideration of biologic width. If you don't take it into consideration, you'll end up getting cases like this. Recession is there, and ultimately, what is happening? The interdental papilla is gone. When soft tissue is gone, it is only a matter of time. Bone will be gone for sure. So we have two ways in case this 3 millimeter gap is not possible. Either we use a scalloped implant. So scalloped is instead of the implant shoulder being straight, it is scalloped like this. Scalloped implants are not so easily available. At least I haven't placed a single one in my life. Right now I place thousands otherwise, but not this. Otherwise, you use the concept of platform switching. Platform switching basically means that the abutment is smaller as compared to the diameter of the implant. Okay, so the advantage of platform switching, abutment being smaller, is because lot of microorganisms occur between abutment and implant. So had it been of the same diameter, the microorganisms would have been in contact with bone as such. Now those microorganisms will be present over the implant surface only. They won't be in contact with bone. To cut a long story short, if you are using platform switched implants, basically what will happen is crestal bone loss would be lesser, but technically the problems increase, especially in single tooth prosthesis. And the abutment screw loosening many a times is more, but that is a discussion for another day. But as of now, please remember, there is a shift of the stress concentration towards a more medial area. So biologic width, this 3 millimeter is more beginning at a more medial side. Requirement is lesser. Even if you end up placing implants closer, bone loss won't be there. So this was another dissertation in our department done by Dr. Shiva. So a very impressive PG student. She had done this dissertation. And in this dissertation, basically what happened was we had used platform switched implants, compared it to normal implants, and ultimately, at the end of 1 year, we had found that bone loss was very minimal in platform switch implants. So please remember the concept of platform switch at least. No dealer should be able to misguide you or something. This is platform matched. The abutment is of the same diameter as the implant. This is platform switched. The abutment is narrower than the diameter of the implant. Given a choice, go in for platform switched. Okay, another important periodontal surgical consideration. Okay, the next is biomodification of implant surfaces. This is the second last. I'll just rush it up now. Biomodification of implant surfaces basically means that all the implants now are sandblasted and acid etched. They are basically roughened surfaces there. But in spite of that roughening, in the first year, lot of bone loss is seen. Whenever loading is done, an implant is properly osseointegrated, but you have given a crown over it. Now what is happening is bone remodeling is occurring. The body is getting used to the stresses of chewing, masticatory forces. So maximum bone loss occurs during the first year, and then subsequently it stabilizes. Ultimately, what happens is it stabilizes, it reduces as such. But the problem is, because of this initial bone loss, many a time soft tissue always follows bone. So what happens is it goes down. So patient starts complaining, doc, your tooth is fine, but I get a lot of lodgement underneath the tooth. It is as if the tissues have shrunk like this and space has come. So what can be done to reduce this bone loss which occurs in the first year itself? We can basically biomodify the implant surface. We can actually make it more active by adding a platelet concentrate known as PRF. So during our PG time, it was PRP. And the moment we completed our PG 2005, 2006 onward, Chokran made PRF popular. So now we basically use PRF. So PRF can be used to coat an implant around on an implant, and subsequently that will be reducing the bone loss. So this was the dissertation done by another impressive PG student of ours, Dr. Divya Dureja. So Divya basically what she did was she used this Chokran box, PRF Chokran box. This Chokran box basically means that after taking out the blood clot from the this thing test tube, you can actually compress it to form this membrane. This is known as PRF membrane. And subsequently, this membrane they were coated around the implant. But she faced an issue in her dissertation. After coating, the moment she was trying to insert it inside the osteotomy, osteotomy is supposed to be narrower than the diameter of the implant to be placed, because over a period of time, what happens is osteotomy has been done, you have traumatized bone, some amount of bone loss will be there. So it has to be narrower. So the moment she was trying to put it inside our PG, Dr. Divya, this PRF was getting squeezed out. Hence, next year, what we did was we modified. I think I've said it reverse. That was Dr. Sachin's dissertation. This is Dr. Divya's dissertation. So that was Sachin, sorry, Dr. Sachin, years back. So next year in Divya's dissertation, we modified it. Instead of coating the implant, what you can do is instead of using the PRF membrane, you can use PRF release it. So release it basically means that once you squeeze the membrane, this fluid which is remaining, this is also rich in growth factors. So what can be done is this is what Divya did, that Sachin did. Sorry about the confusion. So basically what Divya did was she coated it with PRF release it implant. And now you have the membrane remaining. So I don't have time right now. A couple of cases of another impressive PG of ours, Dr. Aditya. What he did was he used to place an implant and then he used to cover it up with a membrane, PRF membrane. So that enhances soft tissue healing like anything. But right now, the objective is what? To prevent crestal bone loss in the first year of implant placement. So basically, she used to coat it with PRF release it, and ultimately by CBCT, we found less bone loss as such. But suppose some patient is not ready. Some patient is not ready for drawing of blood. Patient feels giddy when he sees blood. We have a beautiful, powerful drug known as bisphosphonate, which can be used to enhance the survival of your implant. So these are anti-resorptive drugs, which all of you must be aware. Majority of our parents would be having it basically for osteoporosis, Paget's disease, etc. So this actually increases bone density. So bisphosphonate have been used in perio surgery since a long, long time. So lot of authors had already shown that basically if you were to raise a flap, some amount of bone loss occurs. There's something known as RAP, regional acceleratory phenomenon. The crestal bone tends to go down. So what they showed was that after reflection of the flap, if you were to take a cotton pellet, dip it in bisphosphonate solution and apply it on the alveolar crest, that bone loss won't be there. Okay. So based on this, one of our earlier PGs, again, impressive PG, Dr. Ambika, we gave this dissertation. So this was again, I think 10, 12 years back, if I remember right, Ambika's dissertation. So what we did was we placed one side normal bone graft, other side bone graft mixed with bisphosphonate, enhanced with bisphosphonate. And this bone graft formed faster bone, more bone as compared to the normal bone graft. So based on this success, another dissertation, one of our another PGs, Dr. Shabnam, what we did was we ultimately decided to modify. Shabnam modified the implant surface with bisphosphonate. So the basically the thing which was done was in alpha bio implants, osteophos, a second generation alendronate, second generation bisphosphonate was used. After mixing, the implant was dipped in bisphosphonate and the remaining solution was irrigated into the osteotomy side. Now in this you have to be very careful. Bisphosphonate is a very powerful drug. Okay, it has a lot of strong effect on bone, but it is caustic. So basically, no spillage should be there. Wherever it will spill, what will happen is ulceration would be there. So you can modify your implants with bisphosphonate, easily available, but don't let it spill over. Okay, please take care of this thing. And in this dissertation, again, very nice results were there. Few other dissertation, Dr. Subuhi's is going on, in which we are modifying it with another drug, simvastatin. So what I mean to say is, see, knowledge is power. The more reason why Dr. Shabnam's, Dr. Subhi's, Dr. Divya's, Dr. Sachin's dissertations have been so successful is because ultimately we are using the modalities which are easily available chairside. You just have to pick up a tablet, crush it, dissolve it, and dip your implant inside this thing, and you are enhancing the results. Is that difficult to ask? But then again, your knowledge has to be there as a doctor. Okay, so please understand. With this, we move on to the last point: implant maintenance. What are we supposed to do once we have delivered the implant? So please remember, there are two main instructions which I always give once I am discharging a patient after giving implant crown delivery in my clinic. It is never discharge actually. The patient has to come back again and again for maintenance, checkup, etc. But the first rule is never ever send an implant in which you have delivered a prosthesis in the posterior area without advising an interproximal toothbrush. Please understand, you are having a tooth which is multi-rooted, and now that multi-rooted thing is gone and you have replaced it with a single pillar in between, the implant, a molar tooth. Now you'll be having space on this side and this side of this pillar. Without an interproximal toothbrush, what will happen is over a period of time, this implant will fail, bone loss will start. So please advise oral hygiene maintenance. The second thing is I showed this diagram. This is not my diagram. I took it from the internet. So I tell it to each and every patient. Please have a look. This is your natural tooth. Natural tooth and bone has a nerve in between known as periodontal ligament. Periodontal ligament has something known as proprioceptors. Proprioceptors are pressure sensitive receptors. The moment we are eating something and something hard comes, straight away we tend to open our mouth. My goodness, this was too hard for us to chew. This is not the case in the case of implant. A very powerful tissue, periodontal ligament, is missing. It is osseointegrated. The implant is directly bound to bone. So in such cases, what happens is we tell the patient, please chew food with this implant, but do not test the implant. Do not try to see how hard I can chew. Because if the patient increases the pressure, there are no pressure sensitive receptors to tell the patient to stop. So what will happen is titanium, even though the modulus of elasticity is closest to that of bone, that is why we choose titanium, not because of any other reason. So, but still the modulus of elasticity is 5 times more. Grade 5 titanium is 5 times more rigid than bone. So titanium, the implant will get compressed less when the patient is chewing hard. The bone will get compressed more. So this junction between implant and bone gets dislodged. So please understand this thing, these two, and ultimately regular checkup. Please call the patient for plaque assessment. Periodontal ligament is a very powerful tissue. Please understand, maybe few orthodontists would be attending, might be attending. Orthodontists owe their livelihood to periodontal ligament. Had periodontal ligament not been there, the speciality of orthodontics wouldn't have existed. So plaque assessment, little bit of plaque also is harmful. We have to maintain plaque in this thing. Evaluation of peri-implant tissues, we have to look for early warning signs, color change, redness, contour, consistency, etc. Check for bleeding or suppuration. Something is going wrong. And then finally, peri-implant probing depths. In this, normally we used to say 3 millimeter. Less than 3 millimeter is sulcus, more than 3 millimeter is pocket. Here, what happens is till 5 millimeter, it is acceptable. So not to worry, till 5 millimeter is more acceptable. More than 5 millimeter pocket depth, warning signs, something is going on. So always remember, steel is more rigid than titanium. Do not use your normal stainless steel probes. You have to use plastic probing instruments only. Beautiful instruments from Hufredi. These are the ones which should be used for probing. And in spite of all this, be prepared for complications. Okay, implant is one thing which ideally should be there for a lifetime. So lifetime maintenance of a prosthetic unit in the mouth requires a lot of hard work. So please understand that whenever peri-implantitis is there, that is bone loss is there around the implant, you have to first identify the type of failure. So we have three types of implants: ailing, failing, and failed implants. The treatment modality varies among all the three. In ailing implants basically means you are taking a radiograph and you are seeing constant bone loss is there, is occurring, and at the same time, no soft tissue changes are there, no inflammation, nothing. So not at all. Just like gingivitis always precedes periodontitis, perimucositis always precedes peri-implantitis. So that means this bone loss is not related to plaque. It is related to prosthetic factors. Maybe the crown has been given too huge or something. You have to intervene in a prosthetic manner if possible. Second are failing implants. Bone loss is occurring and at the same time soft tissue inflammation is there. Surgical intervention as a peri-implant surgeon required. What intervention, that I'll tell in short right now, but you need to intervene. Okay. Mobility is there. Failed implants. Mobility is not a late sign, it is the last sign. Now nothing can be done. Mobile tooth can be made stable, be it because of periodontal reasons, endodontic reasons. Mobile implant cannot. Mobility is the last stage. You take out the implant, curate it properly, maybe place another implant or bone graft it, and at a later date you can set. Do not waste the patient's time and money in trying to save a mobile implant. It has already failed. But what about failing? What are you supposed to do? Just two tips I'll be giving, not these two tips, two tips in general. Okay. First is, after reflection, you cannot use stainless steel curettes. You have to use plastic curettes. So beautiful plastic curettes 4R4L Universal Columbia are available from Ufridi. They write single use, but it is not like that. They can be sterilized many times. They are sterilizable. You can use it many a times, but the problem is still they would be less stronger than steel. So they tend to break over a period of time. Plus, they are flexible. More time is required for the debridement. So give it time. Second thing which you are supposed to keep in mind when treating cases of periimplantitis is, see, with periimplantitis, there is infected tissue present underneath the gingiva. You need to remove that infected tissue. If you don't remove, bone loss will continue. After removal, you might not be able to regrow the bone which has been lost, but at least further bone loss would be prevented. Okay, so please understand this thing. So now what you have done is you have removed the infected tissue with this plastic curettes, right? But implant is a screw. You have screws like this. Naturally, some amount of tissue would be present between those screws of the implant. So in those threads, always and always, you have to go in for chemical disinfection. So tetracycline hydrochloride can be used 50 milligram per ml, but please never ever close a case of periimplantitis treatment without giving tetracycline or any other antiseptic for that matter. And of course, now you need to place a bone graft, but the problem is retention of the bone graft. So if you were to place a membrane around a tooth, it is easier. You can just suture it around the tooth. But the problem is basically that placing it around the implant, there's something known as tack. Tack is like a nail. Unless until you nail it in place, your membrane is not going to stay. So this tack kit again is not very expensive. Just now I had to change mine, that I got a little expensive post corona, around 8,000, but otherwise they generally are available in the range of 5,000 as such. So basically you have a nail picker, tack picker, and you have a chisel, basically a mallet, I'm sorry, and you just put it inside. So simple tips, very cheap apparatuses which you need to have if you have to become a successful implantologist. So again, finally the slide, and I'm completely on time, 1 o'clock X sharp. So the slide which majority of the people wait for in a presentation, in a hall at least. So I hope this is not the slide which people would be waiting for my 2 o'clock lecture in our implant academy today. So conclusion, see, basically the eye doesn't see what the mind doesn't know. So knowledge is essential. We are doctors, we are not technicians. Okay? And even a technician can showcase his lab work or something. We are supposed to know the underlying biology. Biology basically means the anatomy, physiology, etc. Unless and until we are appreciating bone and soft tissue, we can never be a successful implantologist. We might get away with a couple of cases where we have placed ample and more implants where bone was ample. But the moment bone loss starts, if our eye is not there, the eye doesn't see what the mind doesn't know. If you're not able to identify, my goodness, buccal bone loss has started at the second stage itself. What am I supposed to do now? Straight away, the instruction to the lab, the buccolingual dimension of the tooth can be a little lesser. Instruction to the patient, first bite, try from the opposite side, something of that sort. You'll have to intervene, or regeneration if possible, try particulate bone grafting. Okay, so this was just the tip of the iceberg. I was, Bennett sir had told 1 hour exact. You speak for hours at end, so I cut it short as much as possible. As much as possible. This is just the tip of iceberg. Lot of this thing is remaining. Any one of you who wants to learn more implantology, more advanced implantology, is most welcome to join our Department of Periodontal and Implantology, Subharti Dental College as an MDA student, or if you are a practitioner, you can join our Rochelle Implant Academy at Lokpriya Subharti Group. And this was not supposed to be an advertisement, but it came out that way. I'm sorry. So thanks a lot for your patient listening. Whichever queries are there, I'll try to address them right now also, but not an issue. I think this recording is there on Facebook or something. Any queries later on also, all of you delegates are most welcome to either email me or WhatsApp me. I might not be able to answer that time itself, but I'll be answering that time for sure, that day for sure. And again, I am thankful for the honor given to me by the organizers of World Implant Expo 2021 for having me as a guest speaker here. Thanks a lot. Jai Hind.
Thank you so much, sir, for taking out time from your busy schedule and joining us on our World Implant Expo. So, sir, can we take one, two questions, or we can just note it down and reply them
No, no,
afterwards?
we can take. But first question is describe 1, 2, 3 principle again, please. And then that is the first question.
Right, sir.
So 1, 2, 3 principle. See, all of us have to understand 1, 2, 3 principle. We are talking with regard to delayed implantology. That is, healing has already occurred mainly, and immediate also, but it is easier to understand with regard to delayed implantology. And I'm talking about right now single tooth replacement. Let's say 3/6 is missing, and it was missing since a long period of time, and the patient has come to us. Patient wants an implant to be placed with regard to 3/6, right? So with regard to 3/6, sorry, this side it is mirrored thing. Now what do I have to look for? Once the flap is reflected, or maybe in my CBCT, I need to understand firstly whether buccolingual ample thickness is there in the this thing or not. Or better still, if you go retrospectively without raising a flap, but from a 1, 2, 3 point of view, I am making you understand in this manner that bone or dimension space needs to be available in three directions. First is buccolingual, that is the bone which should be such that after implant placement minimum 1 millimeter bone should be remaining on the buccal side, 1 millimeter should be remaining on the lingual side. This is rule number 1. So let's say bone is 6 millimeter wide buccolingually, which is the maximum implant diameter which I can place. It is 4 millimeter. I cannot go beyond 4 millimeter. After 4 millimeter, 1 millimeter would be remaining on the buccal side, 1 millimeter on the lingual side. Now, second thing to consider is mesiodistal distance of the tooth, mesiodistal distance between the anterior tooth and the posterior tooth, whether space is there ample or not. So, my implant which I place ultimately should be such that after placement, minimum 2 millimeter for the biologic width should be present on the mesial side, 2 millimeter on the distal side. This is rule number 2. What does that mean? If I have to place a 4 millimeter implant in this edentulous space, what should be the dimension of this edentulous space? 4 plus 2 plus 2, minimum 8 millimeter. Otherwise, I cannot place an implant. There's no point in placing a diameter less than 4 millimeter for the molar tooth as such. Okay, this thing. Third thing, once the patient bites, occludes, the distance from the soft tissue to the antagonist should be minimum 3 millimeter, so that at least a crown can be placed over the implant as such. Okay, so this is the third dimension. Cervicoincisally, 3 millimeter should be present. So 1 millimeter buccally and lingually, 2 millimeter mesiodistally, and 3 millimeter apicocoronally. I hope it is clear. Okay, and the second question is, sir, does inter-implant distance or implant alveolar crest distance, uh, 3 millimeter, inter-implant or inter-implant alveolar crest distance? See, inter-implant and implant alveolar crest would be one and the same thing basically. Like we are supposed to place an implant. We are supposed to place an implant. I feel subcrestally only. So supracrestal is out, equicrestal, some bone loss invariably occurs. So we have to go subcrestally, preferably. So once we have gone subcrestally, this thing and this thing, or you might be asking with regard to immediate implants also, maybe. So immediate implants also after particulate bone grafting, if it is more, it is better, but minimum 3 millimeter inter-implant distance has to be there. Otherwise, biologic width will be violated and bone loss will be there.
हाँ
Okay,
बेबी
and
काम कर रही हो फ्री हो काम कर रही हो, बताओ.
yes. Somebody is having a nice conversation. Okay, not an issue. Can you talk on platform switching in brief? Okay, that was the maximum brief I could talk about, Jyotsna. See, basically, what happens is platform switching means implant of a wider diameter and abutment of a narrow diameter. So this was something which was found by mistake by Lazaro and Porter. So basically, what they had was they had wide implant, but they didn't have the wide abutment. So they placed narrow abutment, so less bone loss was there. So in brief, what I can say is that if your implant is wider and the abutment is narrower, less bone loss would be there. Prosthetic challenges come. But given a choice, If you get platform switched implants, that is abutments for implants, anytime use them. During second stage surgery, any particular incision to preserve the papilla, yeah, papilla preserving incisions can be given as such. But my experience has been such that whatever recession of the soft tissue has to occur, has already occurred after tooth extraction. No further this thing recession occurs. So even in spite of trying to give papilla sparing incisions in that narrower space, single tooth space, and not being able to visualize the bone around the implant properly, I would prefer give it from tooth to tooth, crestal incision, reflected properly, have a look at the bone around the implant. That is more important than trying to preserve that soft tissue, because whatever recession had to occur, it already occurred. Okay. Second is, how long can you wait to get an implant after bone graft? Excellent question. See, normally I am not in favor of immediate loading. So this depends on the density of bone. So normally in mandible, we say 3 months, maxilla, we say 5 months after implant placement. The moment you have gone in for regeneration, add 2 months more, ideally. That is ideal. That is 5 months to 6 to 7 months, ideally. So another 2 months added to the healing period based on the bone, mandible or maxilla, in case you are using a regenerative bone graft around the implant. Okay. Uh, uh, Sudeep, is it mandatory to use non-resorbable sutures if you place graft and membrane? Not at all. Not at all. I don't even remember the last time when I had used non-resorbable sutures in my practice. I am totally in for undyed vicryl. So PGA, PLA, undyed. The case which I had shown in the beginning, that 2 implants placed here, in which primary closure was obtained, always and always, I always preferred resorbable suture. So undyed PGA, PLA is a beautiful suture. It resolves in 16 to 20 days. Hardly any tissue inflammation, strength is good, and give resorbable. Patients don't prefer non-resorbable nowadays. The first thing the patient asks is, will I have to come back for its removal, or will it dissolve itself? So we have to tell dissolve itself. So silk is a poor man's suture, don't use it. PTFE is good, but PTFE again doesn't serve any additional purpose according to me. Non-resorbable is better. Okay, so this is it. Okay, one more has come. Two more have come. Okay. Krishna, is it possible to place an implant when the distal tooth has been moved and mesially angulated? No, no. See, you need space. Okay, it is always retrospective treatment planning. You have to look. It is prosthetic driven surgical treatment modality. So you have to look basically at whether space is present for a tooth or not. So in case it is mesially angulated, now it is up to you. You go ahead with a root canal treatment, try to make it straight, orthodontic correction, or maybe extraction or something. But ultimately, space has to be there for a tooth to be placed where you are planning to place an implant. If is this the question, right? When a distal tooth has been moved mesially and this thing. So you are asking mesial to that tooth, whichever is mesially angulated. And in case you are planning to ask with regard to that tooth, it can be taken out and placed. That is not an issue. Implant placement along with bone grafting, what is the time we should? This just now I answered, Krishna. Okay, Chaitanya, just now I had said that add 2 months at least. Add 2 months at least. Meaning like 3 months, add 2 months, 5 months, and then this thing. What do you say? 5 months, add 1 to 2 months. Okay, this much is meant. Like many a times we are lucky that patient which I showed 4.5 months ample regeneration was there, but that luck doesn't normally favor a periodontal surgeon majority of the time. So we prefer to play safe. Okay, okay, that's it. I think. You know? Are you there right now?
Yes, sir. Yes, sir. So we have more questions. So
Where?
just no, sir, in the question and answer list.
Any question answer I have covered till the last, I think. Chaitanya's was the
Okay.
last. I've
Okay, then
covered till the
done.
last.
Yeah, we are
Uh-huh.
done. We are done.
Good.
So thank you so much, sir, for being with us, for taking out time from your busy schedule, and for this amazing session. And I'm sure that each and every doubt has been totally cleared with all the participants. So
Thanks a lot, Dr. Aditi. Thanks a lot.
So, with this, we are ending this session. Thank you to all the participants for joining us, and stay tuned for more events which are lined up for the day. Thank you, and have a great evening ahead.
Thank you. Jai Hind.